Yes.
Thank you, Sara. Okay, shall we move to the next session or?
Yes.
Okay. So it's my pleasure to introduce Dr. Sara Abdelgalil, who is a pediatric consultant in the NHS, and she has special interest in IT, immunology, and allergy. She graduated from the University of Khartoum with Lord Kitchener's and Al-Baghdadi prizes. Sara is involved in several projects linked to child safeguarding, quality improvement, safety and governance, and she was nominated in the top 100 influential women by the BBC in 2019. Sara, the floor is yours, and please allow me 5 minutes before the end of your talk to draw your attention to that. And I think, Hani, would you like to explain to the audience what we are going to do in the part of the workshop?
Yes, so Dr. Sara is going to talk about human factors in clinical pediatrics and daily pediatric practice, which is an important topic affecting all of us on daily basis. The session is going to be, so Sara is going to talk about the theory bit of it first to start with, and then mention some kind of experience that she had in her own hospital, so she can give an example for people of how, you know, to break down the elements of human factors. And then at the end, we are going to split people into few rooms if the numbers are massive so far. So we'll find out, we'll split people in 2 to 3 groups, and then they can discuss clinical cases and come back and discuss with Sara about what aspects. She will tell you what aspects she wants you to look at in each case and how to present it. And then this will be towards the end of the presentation. And then there is also going to be a poll at some point in the presentation, but we'll get to that. I think Rehab will share the presentation from her side.
Yes, ready, Sara?
Yeah, I'm ready. طيب السلام عليكم جميعا ومساء الخير مساء النور. Good afternoon for everybody who is attending. I understand that there are some audience who prefer to speak in English, but I may sometimes just use some Arabic words. So discussing or talking about human factor is actually a very important aspect, especially for us who were trained and graduated overseas, and then we have joined the NHS. First of all, I would like to congratulate all of you, because already you have done a great job by, first of all, graduation, then postgraduate training and your membership exams, wherever you are. So you have to be proud of that. And then you have to come, as Hani said, to the how you would apply and how can you convince, in your application that you are ready to join the specialty training. And this is not the most difficult part. I think you've done already the most difficult part. So at the moment, wherever you work, we know that patient safety and quality of care is the main sort of the core of our work. And people have moved away from the individual work pattern to the teamwork pattern to the system work pattern, because health service is like other complex services. There are a lot of factors that are involved, influencing each other, that at the end will affect the outcome. So if we go down about, I'm sorry, my presentation is a PDF. If we go down, we have to scroll down about what does the human factor mean. This term it's not a very recent term, but it has been now used more frequently. But it looks at the interaction between 3 aspects: between the individuals at work, between the task that they are doing, and between the workplace, the environment itself. So as I said, we have moved away from just looking at individuals. And it's a science, actually, and it has been established to understand how people can perform under different circumstances and how can they perform well and easily, and that their outcome will be right. And this is very important in health, but in other aspects like aviation, in the army, they have been looking at human factors for longer than the health services. So basically, it is trying to say, how would we do our work easier, and how can we do it right from the start? There's another definition for human factor, that it is a study that looks at the relationship and the interaction between the human themselves, the tools and the equipments that they are using in the workplace, and the surrounding environment. And if you look at, let's say a normal day at work, possibly you will have to come, park your car or come in a bus, then print the handover, so a printer, computer, use software to write and prescribe. You need the ECG machine, the nurses need pulse oximeter, we're using the phone, we're using different equipment, and the trolley, the cannulas, the LP. So there are a lot of, sort of equipment that we are using. It's not only about the human beings delivering the services. Why is it important? Why? I think it is very important if you are starting in the NHS or wherever you're working, is that you see how the system will interact and how this system can be efficient, creative, productive, and how can the individuals be satisfied? Because if we can't work together efficiently and we are not satisfied, then we will have errors. And we have to realize that errors will take place. And the only way to prevent or predict earlier is to have a functional system. So you can have a very brilliant individual, but that individual on his or her own will not prevent errors. So, is there anybody who wants to communicate? Okay. So if the principles of the human factor fail, then we will have more adverse effect in the healthcare. We will have poor quality services, and you will have staff who are not happy, who will be off, there will be absence, their performance will be poor, they will not be creative, they will not be initiative, they will not be innovative. So it becomes like coming just to work and leaving work, but without enjoying what they're doing. So patient safety and quality improvement, and I'm sure you all are aware of the two concepts and hopefully had some sort of involvement with quality improvement projects and assessment of patient safety, and you have read about it or you have done a course. If you can, please do. Are closely linked to the human factor. And they are very, human factor is very relevant when we talk about patient safety, because at the end of the day, what we want to do is to provide safe care. This is why we work in the health sector. And some of these examples is like safe prescribing. This is number one, and it is a big issue in pediatrics because of the age, the weight. Some of the medications are not licensed, and therefore prescribing medication is something that you have to master. Then the other thing is about communication. Is there someone talking, Rahab, or asking for a question? Or communication is very important, and the communication, either verbal communication or written communication, and this can be in different ways and forms. For us, as an overseas, and I would like to reflect that, if you don't mind, it is something that we need to observe, learn, and practice, because it is a bit different, from what we have studied, what we have learned, how do we practice, whether back home or in other countries overseas, and when you move to another country. So communication can be different in different settings, and it's something that you just don't go to only a course. It is something you observe and practice, reflect, and have a feedback on it as well. One of the most important example of human factors is the handover. information between different health professionals. So when you see a child brought from the theater after surgery to the ward, or a patient brought from A&E to the pediatric assessment unit, and the handover between the nurses or the handovers between the doctors, we take that as guarantee. We take it as, it's an easy task. In fact, it is not. And now it's becoming more standardized and stratified that the handover should be performed and delivered in certain ways. And you can give us later some example from your own trusts. There has been an increased complexity within the health service. We know, if you look at the history of health services, it moved now to different levels, different medication, and different sort of operation. And therefore, with this complexity, there are a lot of factors that are coming into display. So it's not all. I think when I was in a medical student, it was about the consultant. The consultant is, sort of the main leader of the unit, and just people will listen to what he says, and that's it. It's a big responsibility. But at the moment, that's not the case. At the moment, every member of the team will play a role. And during COVID-19, that was very, evident, whether a porter, a dietitian, lab technician, a nurse, every part will play, everybody will play a part. And therefore, if they are not well connected to each other, then the team will not work in a good way. We have different policies and we have different equipments, and we have to make sure that we know about them and we learn about them. Currently, after the COVID-19, some of these tasks are delivered face-to-face, and others are remotely delivered. And that will bring us to the digital literacy. So you may feel like the junior colleagues here in this call may think that it is easy to use, computer, smartphones, and navigate. It is not as easy for me as well. I may know a little part, I don't know. I can't say that I completely know how to use all of the digital platforms. And therefore, there are some work to be done and development to learn, for example, about digital platforms as we are moving more towards e-health or electronic health. The science of human factor has developed and is taught now in schools, but it started, as I said, in the aviation, manufacturing, and military services before it came to health services. The same is about quality improvement concept. It has been in the health services for 30, 40 years, but it has been in others for longer than that. And they have learned that without having a team approach, good communication, there will be a lot of errors. And imagine an error happening, inside an aeroplane when it's just high in the sky, and there will be a disaster. And you will just have to work with your team to sort that out. What they have learned as well is any member of the team, any member of the team has the same, rights and responsibilities. So if any member of the team, doesn't mean that the captain, for example, the pilot, will have a better position. Any member of the team can say, hey guys, I'm not happy. There's something going there. And all of the other members of the team will have to listen to that person and investigate, not to ignore what they have been saying. So when we look at the human factor, we do not look into individuals. As I said, we look at the whole system, the whole team, the policies, the protocols, the communication, and the interaction. So in simple terms, if you have a policy about how to treat sepsis, it's writing the policy, having the guidelines, and it looks, well written, nice document. That's not the end of it. It doesn't make any sense if it's just a written document. How will you implement that on the ground? Who is responsible? Who should know about it? How will they communicate with each other? What sort of tools you need? What investigations do you need? What is the outcome? So taking that protocol and implementing it is going to test your human factors principles on the ground. All of what I've been mentioning is evidence-based, is depend on a lot of research, that an efficient teamwork and good communication interaction will, the result will be a good outcome. And the other way around, that if a single, زي ما نقول في السودان اليد الواحدة ما بتصفق. Simply that's the bottom line يعني. Some of the, in pediatrics, because the topic today is about clinical pediatrics, some of the areas I would like you to look at and consider, and I'm not talking here because of the exam or because of the interview, but definitely these are areas that you will be explored to see whether you understand that or not. It's about, as I said, medication and prescribing, handover information, about transport, whether it's intra-hospital, within your hospital, or referral from outside, because these are very complex activities. You may think it is not, but actually they are. But there are others which about software, as we spoke, and hardware like pumps and ventilators. So if you're joining a neonatal unit and people assume that you will know how to run the ventilator, and you are standing there and say to you, can you please adjust the setting? This is the blood gas, and you are in your second day in the neonatal unit or in the pediatric intensive care unit. And oh, these are the new doctors, and they just hand you a gas, arterial or capillary or whatever, and they ask you to adjust it. And you haven't, worked before in a pediatric intensive care or in a neonatal intensive care. You don't know about the ventilators. You had an induction, basic information. What would you do? So this is not uncommon. It is better now. Things have changed. There is more support in units like the intensive care units. But before, people would have assumed that, you know about the ventilator, you know how to use a ventilator. Another example, if you are in a retrieval team and you are in a transport team, it is now about human factors, about training, about simulation. And simulation is about human factors training as well, because then you have the scenario, you learn, and you try to mimic reality in order, if you face that scenario, you know how to act. القصة دي, and allow me again to speak in Arabic please, زي انت بتتعلم سواقة العربية. لما تبتدي السوق العربية بتكون في الأول متوتر وكده، بعد فترة وبعد كم سنة بتلاحظ إنك أنت ذاتك ما بتفكر، وإنما أنت عارف إنك تقيف وين وتعاين وين stop, and you know where are the risks, and you know where to stop, and what are the factors that you have to apply when you are driving your car. Coming back to quality improvement, I would like to mention that process mapping, one of the tools that you can use in quality improvement project, is important about testing the human factor. Because if you take any example, outpatient, and you have problems in your outpatient, and you do the process mapping, the whole journey for your patient, then you will identify all the factors that are good and positive, and all of the risk and the potential gaps. And that will, then you can improve your performance by trying to maintain the positive practice and trying to sort the negative practice and fill the gaps. So if we move down to, so we talked about the quality movement, about the process mapping. If anybody has got a question, you can ask me later about it. Then if we go down to the human and organizational factors, which is in the next page. Thank you, Rihab. If you look at this sort of semicircular course, we look at the right, the left side, about managing human reliability. So the human factor, ببساطة, says that as human beings, we are not reliable. Okay, I can know what to do. I can come and try to put the cannula, but I can't. Yeah, في a lot of factors. Yeah, it doesn't mean that I can't put the cannula. I try to do a lumbar puncture that day, but I fail. But doesn't mean that I don't know how to do the lumbar puncture. I, you know, was coming to work, and then, you know, something happened to me. I woke up with a fever. Okay, so you cannot basically rely on human beings. That's a fact that we have to first of all agree on. The other thing is we, as human beings, unpredictable, as we said, for different reasons. We can forget, we can get tired, that can affect our memory. And therefore, the other factors are trying to maintain or fill the gap to make sure that we are more reliable. Some of these may be the procedures that we apply, the training and the competencies. That's important to make sure that your competencies are up to date and you have good training. Just a moment, I just have to stop my son from doing something. Sorry. The staffing and the workload, so that you can fill the gap if someone is off sick or someone is stuck with a sick patient. The culture of the organization and the ability of the organization to move, change, and to be responsive. The word is responsive. And COVID has tested our responsiveness. For some organizations could change and apply different methods, others couldn't, and it means that they have a very rigid culture. About communication, as I said, it's important about safety, and it can be very, very critical, whether it's in safeguarding, whether it's a sick child, whether it's just about the staffing. So communication is a very important factor. When we are designing a software, and I think there are some colleagues with me in the call here, they can reflect on this. When you are designing any software for people to use, it should be designed for those people to use it. So you can't just purchase a system or a software and then bring it and then people can't use it. So that's going to be inefficient. People can't work then. And therefore, designing for people, getting people involved when you are designing something for them to use. Fitness for work. We have the responsibility to declare if we are not fit for work. This is a legal requirement, but as well, fitness for work is not just the physical one, it's the mental health as well. And the tiredness and the stress can affect our fitness. We spoke about the culture and the safety culture, and I think generally the culture within health sector, whether it's in the UK or in different areas, have changed, but still there is this hierarchy, and still, you know, there is some, you know, you feel you're a junior doctor, maybe I should not say that, I may upset the consultant, I may upset the registrar, they may not write for me the recommendation, they may not write good things about me in my ERCP and so forth, which is something people have to stand up for and try to demolish, especially by having a trainee representative and having trainee meetings, because this is very important. And, you know, as member of part of the team, you have to have your voice heard. Maintenance, inspection, and testing errors. As we can see, sometimes, you know, people coming to test the light, to test the fire, to test the machine, to inspect like this CQC, to make sure that, you know, there is an external independent review, because you yourself might not identify the problem. You get used to the system. This is how it works. That's the best way. I don't want any change. But if you have some, you know, inspector, independent inspector, they may tell you, actually, no, that's not the best way to work. There are better ways to do this job. So if we move down, and I'm aware of the time, about the factors affecting human factors, we talked about the fatigue, the stress, and the poor communication. And we talked that humans are not machines and they are not predictable and reliable, but human beings are creative and they have the imagination and the flexibility, and that's very important. And there is at the moment, I wouldn't say that there are two groups all for human factors, and another group who are all for artificial intelligence, and whether artificial intelligence can only support or should it replace major parts for human beings. And I think this is an interesting discussion. So in the next page, we're reaching for the first poll. So if you come and you're working in a trust or a hospital, or you're coming to work in the NHS and you know about what is NHS England and what is the NICE guidelines and all of, how many here are aware, and you have to be honest, Yani, how many of us are aware of the vision and the values of the trust where we work?
Okay, so do you want me to put the poll now, Sara?
Please.
Okay.
So are you aware that your trust has got a vision and there are values in your trusts? Are you aware of them? Do you agree with the vision of your trust? And do you practice the values of your trust? Were they mentioned in your induction? So the reason why we are discussing this, because, yeah, are you aware? The reason why we're talking about the vision and the value is because human factors is about working together and bringing people together to have a common, vision, to practice and agree on the same values. I'm working in the corridor, and then there came a nurse that I don't know, and we found someone doing anything in the corridor that we felt does not fit with the vision or the value of the trust, any other member. We have to take action, or we need to help that colleague, or we have to raise concerns about it, whether that's positive or negative. So it brings this connection between each other without even knowing each other.
Can you see
I don't
that?
Is it, can we stop it now? I think most of, I don't know. I can see the results, I think. Are you going to share them or?
We shared them already. Did you want me to share them again?
No, thank you. So only 11, I think, from the whole, but thank you anyway. So it's important that you know about the vision and the values of your trust. And for you as trainees, you move from one trust to the other. It will be interesting to see which each trust have its own vision and its own values. But the NHS overall, NHS England has got a vision and values. These are very important, and they should be bringing people together as one team. So if we go down to what causes error, and when we talk about error, because we don't want to cause error, we want to prevent error. So a busy ward, number one, I don't think anybody will disagree. If you don't have enough storage, so you don't have your equipment, and then in the middle of a resuscitation, or you have a delay in getting an equipment, and then the patient deteriorates. If you're not familiar with the equipment, as we said, if the staff were not involved, so you're bringing for them an equipment, a cannula that they really don't know how to use, a pulse oximeter that they haven't, they don't like, they prefer another one. But just a decision, whether it's cost or whatever. The equipment are not standardized, so you are in a crisis and you need to move nurses, but then the nurses in Unit A cannot use the equipment in Unit B, although Unit A and Unit B are in the same trust. You are changing in the workplace and the patient journey within the trust, but the staff are not involved, and then you don't know what's happening. And there's different examples, I think, that we can talk about. The staff is tired and exhausted. And so the human factors, it's about being honest about why we make mistakes as human beings within a system. How can we design the workplace to minimize these mistakes and harm? We will say that's very simple. But when we come and discuss that, we will find in reality, it's not that simple. It takes us away from blaming individuals to reviewing the system. And I think as all of us as individuals, and especially if you're joining a new trust, and there is a mistake, you feel, oh, it's my problem because I didn't know the place. Okay, everybody looking, oh, the new doctor, she doesn't know this, and especially sometimes, oh, she's not from this country. So there will be a lot of assumptions. So obviously it is the system. Even if you didn't know a protocol, then there is a question about induction. Okay, about making individuals aware about the different protocols and policies and giving them time to read it and digest it. So the other concept that I would like to talk about before we go to the scenario is the situation awareness for everyone. And that's I think down in the, and situation awareness for everyone is, or SAFE, is an important concept that you have to apply on a daily basis. You have to look every day when you come in the morning, you have to hand over, you look at the staff, you look at the patient, you understand what are the risks and what are the gaps and what to predict. So if you come to work and then you find you're working with a junior trainee who is a GP trainee, who is a foundation doctor, who's an ST2, it makes a difference. If you come to work and find that HTU is completely full, and then you know, okay, it may take me longer, then I may not have time to do something else. And so you will plan your day if you know that you're coming and there is shortage of in the staff or nurses, or you come to know that today the X-ray system machine, it's not working, and therefore you can't see the X-rays on the system. So you have to assess around you what is happening, what will be the risk, because you will change. The evidence base prove that you will change the way you are practicing when you are aware of the gaps and you are aware of the risks. And obviously there have to be mitigation. So certain jobs may be dropped, certain pathways may be blocked because we don't have, or we have something going on wrong. If we move to the other page, the culture of the team and the culture of the organization. I find it always very difficult to talk about the culture of the team and the culture of organization. And I always question myself, who is creating the culture? You know, you came to an organization and there is this culture, and it takes a long time sometimes to change that culture, whether to the good or whether it's to the bad. And it's the leadership that will make a difference when we talk about culture. In the next few words, I think it's mainly about human factors in relation to us human beings, and that there is more recognition to the fact that fatigue and stress can affect our performance. And I think that's straightforward. Everybody will agree with that. That was reflected on work shifts, rota, and we can find that at higher level. Yeah, the Royal College of Paediatrics can be involved, the GMC, the BMA, the European Working Directive a few years ago, because then definitely your performance will drop. Hospital at night when there are few staff, not like during the day hours, not like during the weekend. But how can you, if you are worried or you are stressed, how can you how can you explore that? If you have stress, anxiety, the first few months in your work, you have to find a mentor. And that can be in human resources, that can be in occupational health, that can be sometimes within certain units, they have mentors, or from an association here, a Rabta, I think, if you come and ask for, someone to informally, they will help you. Mentoring is a good system because you want someone away from that system, someone who will not judge you. Now, we all, like human beings, you don't want people to judge you and think, oh, he may be not, this and this, or make any comments. You need someone to discuss your worries, your anxiety, and to get advice. And that is very important. The last point I would like to say in comparison to pediatrics in surgery, they mainly use checklists, and this have made things easier for them, but it's not always the case. And the first checklists were as well created in the aviation industry. Checklists for a theater checklists like the WHO checklist, but there are checklists as well about they created in the aviation industry for self-assessment about fatigue, emotion, stress, anxiety, mental health. You do this self-assessment. If you get a score, then they will advise you what to do. Okay, whether to seek medical advice or counseling or mentoring or whatever you want to according to what you need. As far as I know, we don't have this full self-assessment. But there are services in occupational health and well-being, in human resources, in each NHS, and it's important that you seek advice if you feel that you are struggling. عايزة أختم قبل ما نبتدي بتجربة مرت بها في السودان so we can so that one of the recommendation for human factors is you shouldn't rely on your memory. ما تقول أنا والله متذكر كل الأرقام ومتذكر كل الدوزز وكده. You have to make things visible. أنت جاي تستخدم حاجة قدامك الجهاز, you have to make it visible. وأنت بتشتغل فيه, you make sure that في معلومات near you so that you make sure that you're checking yourself. Make it very simple, all the procedures and the process. عشان don't complicate things عشان ما بعدك تتعقد لك زيادة. Review the pathways or standardize a common process and procedures. In the whole trust, you're going to train the people to use one machine. You have to get the machine that works in different parts. عايزة أقول كده قبل ما نمشي للكيس ستدي إنه لسه don't memorize everything دي أنا ما أعرف غايته. كنت في سنة ساسة طب and I was told that you shouldn't memorize. I don't know, someone told me that, and then my uncle sent me a BNF, new BNF from the United States, from the United Kingdom. He was a doctor, and I was so happy to have the BNF. كنت recently graduated وكده. I was sitting in Khartoum Teaching Hospital in the A&E, where I had this BNF وخدتها كده قدامي بكل فخر. Then I had two men sitting in front of me. One was the patient, and the other one was probably the brother, maybe. They were talking to me. وما شاء الله, in Sudan, people used to memorize medication. Okay, so they know the medicine, the drug, and the dose, and everything. And I was just like, well, I was told this is not the right way. Okay, I will practice it right. So I took out the BNF. I opened the BNF while I was checking them. Those. I'm going to say that in Arabic because I can't say it in English. فقام أبو أخوه قال لي يا أخي قوم دي لسه بتقرأ ما عارفة أي شيء وما حافظة أي شيء بتجرب فينا. And they left me and they went and sat in front of another doctor. So there is this concept about we should remember everything, and it's part of being a good doctor that we can memorize everything. This is not right, and we have to recheck. I personally, in my outpatient clinic, I have the BNF always online, open, to check the medication and make sure that I'm not making any mistake. So to conclude, before we go to the cases. Human factors, and the next page, Rehab, it is about the way we work, why errors occurred, how to design a better way. So the first, the case studies that we're going to work on will depend.
Sara, do you want the second poll, or do you want to leave it to the end? Or
no, we can go for the second poll. Thank you for reminding me.
can you see it?
So, yeah. So in this poll, we're going to talk about if you identify any gaps or any potential risk within your team that can affect patient safety and quality of care, will you be able to communicate and raise your concern؟ حاسة في الوضع اللي انت فيه ده كويس، هل بتقدر ولا ما بتقدر؟ هل في حاجة بتمنعك؟ هل في مخاوف انك انت يعني تحس انه انا ما بقدر ارفع اتكلم واقول والله انا ما بقدر اقول والله انا خايف وكده؟ ما عارفه انتوا هتاخدوا كم تلت العدد؟ 10 ولا 11؟
Yes, we already passed that point. I can stop it and publish results if you want.
Yes. كويس جدا. We have about 60% who said that they will raise their concern. Excellent. About tilt قالوا maybe. That needs discussion. So if you would like to say if you would like to write those who said no or those who said maybe, if you feel happy or comfortable to write in the chat box why you don't feel comfortable to share your concerns or why you are hesitant, that's maybe. Please share it with us. Obviously this discussion is confidential يعني. We will all يعني benefit from learning. And those who said yes, if you can tell us يعني why يعني you feel very sort of comfortable with that, what are the factors that make you يعني feel happy to do it? If you can share some of these ideas in the chat box, it will be great. So we will move to the case studies just because of the timing. And the case study, the first one that we'll take, we will look into the setting where the story happened, the challenge or challenges, the response that happened and should happen, and the impact that will have not only on the patient, but on the team, not only on individuals, but on the whole team. And how can training and simulation improve the outcome in the next time? So are we ready for me to go on this case, or is time?
Yeah, I think you are going to give an example that happened to you, and then we can get the other cases for the.
Yeah. So we're going to go on an example, and I modified that example because, as I said here, we're talking confidential. We are not going to point fingers at any units or any hospitals, and we don't want that to happen. So we have a setting where there is a pediatric assessment unit, and we're talking about the winter season in the UK, when it's really busy. The unit is accepting referrals from emergency department, from primary health professionals, GPs, health visitor, midwives. We as well would accept children with complex needs who have got a passport or VIP or open access. And sometimes this unit can provide outliers beds if the inpatient is blocked. So you have patients there for 1 or 2 days. So we have an evening shift and we have 16 beds. And but in the department, there are 22. So you have 6 patients sitting in the play area, waiting for assessment. So they arrive, but they have no allocated bed. A child was transferred from the emergency department to the pediatric assessment unit. They have severe asthma, were on oxygen. On the way, when they were coming en route, they had a continuous monitoring. On arrival, they were handed over to a healthcare assistant because the sort of registered nurse were busy. He was placed in a bay behind at the end, behind the nursing station, because there was no other bed. So, and then the monitor was taken back because it belongs to the A&E. There was no, available continuous monitor because all of them have been used and utilized. So he was having spot assessment on arrival and then after an hour. The healthcare assistant within an hour was only seen by the healthcare assistant, noted that his score, his early warning score, has increased, and she was concerned, so she came and informed the senior nurse and the medical team. So the challenge in this situation, that the unit was full. There were several referrals. They were arriving at the same time. Some of them requiring isolation. There was no available cubicles. The huddle or the handover did not take place on the time that was planned for, because people were very busy and seeing patients. Communication was interrupted by the different team members. Several phone calls, and this has led to that. The medical staff is busy, and the nursing staff are busy. The response: the senior medical staff reviewed the patient immediately when they were approached by the healthcare assistant. They requested a portable monitoring because there was no fixed monitor. They attached it and adjusted the oxygen supply, and they then prescribed additional bronchodilator. The senior nurse and the medical staff reviewed the layout of the unit to move the child to a bay near to the nurse station. The impact on the team: they were very tired and stressed. They were not satisfied with their performance. The communication was tense between the different team members, asking, why didn't you do this? Why did you do this? Why there was a delay? Generally, there was delay in prescribing the medication, administration of the medication, and the junior staff were trying to do discharge letters because they wanted to discharge patient in order to have empty space. But that meant that there was delay in reviewing the patient and assessing the patient. And there were guidelines that patients should be seen by within half an hour. So with the training and simulation, in this case, is to consider the patient journey from the emergency department to the pediatric assessment unit or to the inpatient ward, that it's one journey. The early escalation when there is capacity issue, and that will happen within the department itself, and then within the hospital, and with the other units that you work with closely. So, for example, for this child, when they arrived on the ward and there was no monitor, a communication between the pediatric assessment unit and the emergency department, they may have left the monitor because they have extra monitors in the emergency department. Another possibility, if there was good communication, that child may have stayed in the emergency department because it was the safest place at that time. We would weigh the safety against breach and 4 hours limit. The initial assessment after handover, the standard says should be done by a staff nurse that is registered, not by a healthcare assistant only. And that will come to decision making about whether the staff should have been increased earlier or the referral have been stopped until the patient inside the unit have been sorted, trying to maintain the huddle and the communication within the team. So the main areas in the next page, what has been recognized that at 5 o'clock, significant number of the staff will go home. And the majority of referrals will arrive at 6 p.m. And therefore, you don't have a good ratio between the staff, whether nursing or medical, to the patients. As well as the layout and the environment, you have 16 spaces. You don't have enough equipment. So the patient journey within the hospital has to be reviewed. The referral pathway has to be checked. The assessment of equipment and capacity in winter. And the huddle and communication that will come after, if you go down. The huddle and communication within the system has to take place, even with the minimum number of staff. To review the rota and the cover with peak time so that the right number of the staff are present in the right time to prevent fatigue and stress. I don't think this scenario is different or unique. We all have been through this, but if we look at the human factors within this scenario and the responsibility of all different units, not only your unit and not only the medical team, and not only you as a registrar or an SHO, then you can understand how to apply human factors. So there are 3 scenarios. People can split, or I think, I'm not sure what is the number now. I think they
Okay.
split.
We've got almost 27 people around. So before you go through the scenarios, I'm just going to read the names and each room anyone will be in. So we will split people in 3 rooms. There will be no moderator with you inside your rooms. You will have to discuss it with yourself, between yourselves, and come up with the 4 or 5, headlines that Sara was talking about. And then you come back and assign one of you to present your findings or your suggestions for the case or anything. I'm just going to read the names and just it will be room 1 will be case 1, room 2 will be case 2, and room 3 will be case 3. So I'm reading from the names. Ala Farah, Alia Imad, Azza Idris, Khadija Hussein, Muhannad Al-Manna, Rihab Mahdi, and Rihab Shaheen. You will all be in room 1, so keep an eye on the first case. Ahmed Jafar, Ahmed Muhammad Ahmed Abdullah, Fathi al-Sheikh, Muhammad Hamad, Mustafa, Abdul Murdi, Mutawakkil Babikir, and Tagreed. Kullakum will be in room 2. Have a look at the second case when it comes. And the third room and final room will be Amal Ahmed, Fatima, Juwairiya, Manal, Muhammad, Razan Suleiman, and Shayyan al-Siddiq. هنسمع الكيسز في الأول وبعد كده I will split the rooms.
If I can advise you so that you can work properly, is to take a screenshot of the case, because that will help you. Okay, so the case number 1, case number 1 is a 13-year-old boy who has progressive neurological pathology. He requires home ventilation. He's on BiPAP at home. The child is under a neurology team, respiratory, orthopedic, cardiology, and ENT. He was admitted to the surgical team, the surgical ward in the pediatric hospital for an elective operation. He arrived in the hospital at night before the operation to have an assessment by the anesthetic team. The parents were trained to use the BiPAP and they stayed with him overnight. After the assessment, everything was fine. The machine started to beep, flashing an alarm. The parents tried what they know usually, to review the machine and to adjust the setting as they will usually do at home, but the machine continued to beep with red alarm indicating that there was a problem. They never had this before, so they never called anybody at night. They didn't know what was happening. The staff in the surgical pediatric ward are not familiar with using BiPAP. So they contacted the medical team to review the machine. There was no plan about what to do if the machine is not working. The medical team, when they received the call, they were not aware of his admission. And the junior staff read the manual to see whether they can identify the problem. They didn't feel comfortable with that. It was the hospital at night team. There were no members of the respiratory team to help. So the medical registrar, or the medical pediatric registrar, contacted the anesthesia team because they work with so different types of machines. They reviewed the machine and were able to identify the problem and to adjust the setting accordingly. So if you write about the setting, the challenge or the challenges, the response, the impact, training and simulation, how can that help? Consider individual team and the system, and consider patient safety and quality improvement measures. That's for all the cases. Okay, so if we move to case number 2, 9-year-old girl diagnosed with diabetes. She presented to the hospital. She's diagnosed as a walking diabetic, not in ketosis. Was seen at 7 p.m. The decision was to keep her overnight. Initial investigation were done. The medical team provided some discussion about what is diabetes and the treatment, and so that the child in the morning will see the expert team. During the night, they were doing the blood sugars and they were increasing as well as her blood ketone. And so she developed DKA and they were not aware what was happening. The evening handover, when it happened between 8:30 and 9, they were informed that the insulin was prescribed on the electronic prescribing software. However, when they reviewed it, they found that the main prescription was actually in the paper chart. So the initial dose was given, but they have not transferred the insulin dose to the electronic charts. The nurse assumed that the dose that the child has had, that's all that was needed. The prescribing electronic software has just been launched in that unit. And during the initial phase, the paper chart was still there. People were saying, just let's leave it, because in case we need to use it, and there is no delay, if people don't know how to use the electronic prescription, then we can use it as a بديل. This is the second case, and you have to apply the same questions. Case number 3, 4-year-old boy in the emergency department was seen at 3 p.m. with fever and tonsillitis. The medical team decided to prescribe medication to the child. They reviewed his notes, and they noted that he is allergic to penicillin. This was part of the initial nursing triage documentation, so they decided to give him erythromycin. They explained to the family that they're going to give him erythromycin because he is allergic to penicillin. The parents informed the medical team that the child doesn't have penicillin allergy. He had amoxicillin several times in the past. So the medical team discussed with the nursing staff who was doing the triage what has been happening. And around 2 to 3, there has been several children awaiting triage, and the nursing staff are under pressure to complete the triage within 15 minutes from arrival. So they decided to triage the patient and then complete the documentation. And the nurse staff was sure that one of the children she triaged had penicillin allergy. It was clear that the child with tonsillitis was not the index case with a penicillin allergy. However, there is another child in the department who has penicillin allergy, but this was not documented. And which one is the child? Any question in any of the cases?
Okay, if there are no questions, then we are ready to split the rooms. I'm just going to hit the button, and everyone, you will find yourselves in your own room. It will give you about 5 to 6 minutes to discuss and make short comments, and then there will be a countdown from 30 seconds, and then you will be taken back to the main room where we can discuss the cases back again. You are just about to go into your rooms.
Google Digital Garage offers over 60 free online courses and regular live webinars. Learn new skills such as the
السلام عليكم ورحمة الله وبركاته. اليوم في الفيديو ده حنكلمكم بشكل مختصر عن الجمعية البريطانية السودانية لطب وصحة الطفل اللي هي British Sudanese Association of Pediatrics and Child Health أو اختصاراً BSAPCH. هل عندكم فكرة عن الجمعية دي؟ طيب، للناس اللي ما عندها فكرة، هي جمعية خيرية غير ربحية وتعليمية تم تكوينها في المملكة المتحدة سنة 2003، يعني لها زي 17 سنة. من أهم الأهداف اللي قامت على أساس الجمعية دي هي دعم وتنسيق الجهود للنهوض بخدمات الطفل في وطننا السودان، طبعا بالإضافة للمساهمة في دعم الحالات الإنسانية بشكل عام في السودان. وبالنسبة للأعضاء، فالجمعية تهدف إنه تساعدهم في تطوير نفسهم أكاديميا ومهنيا. الجمعية وبجهود أعضائها قدرت تحقق بعض الإنجازات في الفترة الماضية، على سبيل المثال التعاون المستمر مع جمعية الأطفال السودانية ودعمها في عدة مجالات، أبرزها الدعم المادي والعيني وإمدادات لوجستية كأجهزة الحاسوب والبروجيكتور والمانيكانات التي تستعمل في كورسات الإنعاش الرئوي، دعم فريق طبي متخصص في علاج أورام الأطفال من مستشفى نوتنغهام، وتقديم دورات تدريبية مكثفة في مراكز علاج السرطان في السودان، إمدادات طبية متواصلة زي معدات السلامة للأطباء العاملين في الخطوط الأمامية في جائحة الكورونا، تقديم المحاضرات وورش العمل والمساهمة في مؤتمرات جمعية الأطفال العلمية. الجمعية بالتأكيد حتكون الممثل لكل المختصين والمهتمين بصحة الطفولة، وحتكون فرصة طيبة نطور فيها اهتماماتنا المشتركة ونتواصل من خلالها. الفيديو ده دعوة لكل المهتمين بصحة الطفل في المملكة المتحدة وجمهورية إيرلندا للانضمام للجمعية والمساهمة في تفعيل نشاطها من جديد، والخدمة في برامجها لتقوم بدورها الأكمل لتحقيق أهدافها. ندعوكم لزيارة موقعنا على الإنترنت اللي حيظهر على الشاشة وتعبئة فورم التسجيل، وكمان موجودين على مواقع التواصل الاجتماعي اللي حتظهر على الشاشة برضو. شكرا كثير على المتابعة، وزي ما دايما بنقول سوا أكيد بنقدر. الجمعية هنقدم لكم فيديوهات عن طريق السلام عليكم ورحمة الله وبركاته. يسعدنا جدا في الجمعية البريطانية السودانية لطب الأطفال وصحة الطفولة BSAPCH بالمملكة المتحدة أن نعلن لكم عن مشروع الميد توك، واللي هو عبارة عن سلسلة فيديوهات تثقيفية تعريفية طبية كمبادرة من الجمعية. هنقدم لكم فيديوهات عن طريق قناتنا زي الفيسبوك. الهدف من الفيديوهات دي هو مشاركة المعرفة ونشر الوعي والتعريف بمواضيع متعددة تهم المجتمع السوداني، منها ما يختص بصحة الطفولة، إضافة لمواضيع اجتماعية أخرى مهمة تخص المجتمع السوداني بصورة عامة. الفيديوهات حيتم تقديمها بواسطة المتخصصين من أعضاء الجمعية بالإضافة لمتعاونين مع الجمعية. نتمنى من الله العلي القدير أن يتحقق الهدف المرجو منه، وننتظر مشاركتكم الفعالة بالحضور والشير والمساهمة في تقديم الحلقات، وكلنا مع بعض نقدر نغير للأحسن. وشكرا لكم ودمتم. الجمعية البريطانية السودانية لطب الأطفال وصحة الطفولة BSAPCH.
طيب, all the participants will start joining us in probably less than 10 seconds from now. I think we've got everyone back.
Great.
Sara, yeah, I think we can get them to present their stuff.
Okay, if we have everybody's back, I'm not sure if the time was enough or not, yeah, Shabab, but at least you get a flavor. So case number 1, if there is anybody who can share with us their thoughts, please.
People remaining from group 1 are Khadija, Muhammad, and Rehab Shaheen. If any of you can just tell us what about the case. Open your microphone, please. We can't hear you. I think Rehab opened her mic, but it did not. We couldn't hear anything. Try again. Rehab, Muhammad, and Khadija.
Good afternoon.
Yes, please.
I will try to participate. It's first time to me. Regarding the surgical intervention of this case, I think if the patient who needs surgical intervention and he is chronic patient and is under multidisciplinary team, suppose all parts of the team should share before the patient is entering the hospital for elective admission. All team should have idea that this patient will be admitted, and I think the responsibility of adjustment of the BiPAP not inside the hospital will not the responsibility of parents. So I think this patient initially should be admitted, although it is under the surgical, but the other teams must be involved from the start and not to be a sudden participation of them once there happen problem to the patient. This is what I understand from the case.
Thank you for your participation. And yes, I think if we go through this, it's when we're talking about human factors and about system and about teams, as you said, there should be a good interaction and communication in this setting that the child is coming for an elective. So everybody should be aware. There should be anticipation that if this BiPAP doesn't work, who will fix it, either to see whether there is a trained staff nurse in that ward. If there's no staff nurse, then the child should be admitted in the medical ward, although he's going for surgery, to make sure that there's someone who knows how to deal with it, because as you said, we can't depend on the parents. There is the communication. And it seems like there has been as well good communication between the medical team and the anesthesia. And there as well was a good, the surgical team have said their limitation that they don't know what has been happening. The BiPAP was used in the community. People on the ward didn't know about it. It's different from the other machines that they are using. And when you look at the whole system, if you think about it, he was looked by the community team who are dealing with one machine, and there is no standardization with others within the hospital. And that can create a lot of problems during weekends, bank holidays, if the parents are in trouble and then they come to the hospital because they will accept people to sort out the BiPAP. And then they will discover that the respiratory team who were trained are not there, for example, or maybe they are lucky that they are covering the rota that day. One of them is just by accident is there. And therefore the standardization as well is important, and working as one patient journey between community, primary and hospital-based. These patients who have complex needs should have a regular sort of communication and assessment by different teams. The training and simulation is important, so that if there is this case, what will happen, and training the staff on using different types of machines that are available in the community that they can see. That's an important fact. It has got an important impact on the team because they have spent the whole night worried and concerned that this child, they can't provide for him the BiPAP, he can't. At night, this is something which is life-threatening, obviously, and for the family, it's a very bad experience. For the child as well, it's a very bad experience. And from an elective admission, it became a very sort of chaotic admission with a lot of risks. I don't want to talk a lot because of the timing. If anybody else want to add.
I think that was fair enough, at least for the first group. Anyone from the second group who can present their findings? Ahmed Jafar, Ahmed Mohammed, فتحية, محمد محمد, مصطفى, متوكل أو تغريد. أي واحد منكم. افتح إذا اتفقتوا على شخصية افتحوا المايك، أو إذا في واحد عايز يتقدم.
Hello, can you hear me?
Yes, we can.
Yeah. Yes, our case was about this the diabetic child who came at the end of the shift, and yes, the challenge here was the problem with miscommunication between the team, and the second thing is that because there was two different modalities, the paper and the electronic, so that some information were missed. So that, and the challenge that the patient came at the end of the shift, and I think it was not communicated well to the next shift between the doctor or the nurses. For this, the follow-up was not that much. This was a big challenge. So that the child had this error that he didn't receive the subsequent doses of insulin, and his blood sugar start to build up and the ketone at that time. The good thing that the team noticed that there's something, and they go and they found the thing. That is a good thing. But I think if we, from the start, the handover was proper, it couldn't happen like this. They will go and revise the plan, the coming team, the night team. Also, if there is a huddle between the night team after they started their shift and they go through the patient to see the plans for the patient, also this should have been identified also to know that this patient is received only the first dose, and the plan on the software is not available, so that they can reach thing. So I think it was a miscommunication error between the two shifts, and the other thing that there's two different, there's a paper and there's a software that also created this dilemma. Thank you.
Thank you very much. Yes, I agree with you. There are certain areas and certain times of the day where there are potential risks. And if we look at the system, as we said, or we look at the team, we don't know how was the shift, how busy, what other things were taking place. But obviously there was a problem with communication, written and verbal communication, because you will look, for example, the nurses will look at the medical notes and they will know what is the plan, and then they should question that it's written on the medical notes that this child should be receiving insulin at these times, but I went to give it and I couldn't find anything prescribed. So it seems like there was a problem with the written communication. And then there was a problem with the handover, and handover is one of the huge, areas for human factors that people are working on. So it will be efficient and will be standardized. Then there was this problem between software and hardware and using the drug chart, which one, and transferring the medication. The last thing that the patient and the parents, he's a newly diagnosed, so the patient doesn't know, the family don't know exactly, so they can't question. They were not aware of the plan to come and question about what is when is the next medication, what is the treatment. For example, if you have antibiotics, you will expect parents to come and ask, and therefore about as well and knowledge and involvement of the parents and the child themselves about what is the plan. And that will bring us to, we have children, we have hospital at night, but we have as well critical times when we have the staff capacity is usually limited, and you have children with serious illnesses. One of them is neutropenic febrile neutropenia, who have time critical to take their medication. Children who are receiving very, sort of medication that are high risk, like insulin, and therefore these patients should be as from the beginning considered as high risk, and they should be managed carefully. If anybody else have got anything to add, please feel free.
Okay, if no further comments, should we move to the last group 3? في أمل أو أمال، فاطمة، جويرية، رزان، وشيئا. أي واحد منكم إذا قدم لنا just unmute yourself and start talking.
Okay, good evening, everyone. Our case was a 4-year-old boy who came to the emergency at 3 p.m. and diagnosed with the tonsillitis, and he had been labeled as a penicillin allergy. And when the medical team came to describe the medication, they decided on another than penicillin, and they find out from the parent that the patient doesn't have the penicillin allergy. And when they searched out from where he got the labeling, the triage nurse stated that she was at a busy time and she labeled him wrong. And they found out like there is another patient in the department who may have a penicillin allergy without the label, but this one has a wrong labeling. This was the setting. We agree that the problem was like the overload and not asking for help earlier from the nursing who was in the triage, and that's what created the problem. And there was a suggestion that to raise the concerns early and ask for help, so there will be enough staff on the busy time. And also we suggested that to have like a bracelet in the patient once they have been diagnosed or find out they have the allergy. So at this time, if they put the bracelet, maybe the parents would say, no, he doesn't have the allergy. So
Fine. Is that the?
Have you finished, Razan?
I believe so. If there is anyone who want to add anything from the team.
Great. So thank you. So if we look at this case as well, when we look at the system, as you have identified, we have certain peak times in certain units, and it seems like there were quite a few for a triage. There was only one nurse to do the triage. She has to do things within 15 minutes because then she will be blamed that, the audit has failed because they couldn't do that. So she decided to do them all and then to prescribe later, and then she put the wrong label on one side, and then what happened. And the prescribing and the checking of allergy is one of the major issues within health services all over the world, because when we come and say that the doctor have reviewed the notes and discovered that the child is allergic, is that enough? I've put an asterisk. That's not enough, because as part of the history, this doctor should have asked the patient themselves within the story, within the history, is your child allergic to any medication? And then the family would say, no, he's not allergic. It is good that he has looked, but that's not enough. We have to ask, because there is a lot of issues about allergy. So we have to look at the capacity, and most probably the doctor as well was trying to see the patient quickly. And, you know, this child has tonsillitis, so I can give them antibiotics and they can go home. But then you have another child who's sitting in the department who has got penicillin allergy, and this child may be unwell, and then people decide to give him, for example, IV penicillin, or discharge him on penicillin if he's well. But especially if the doctor did not ask him and say to him, do you have allergy? Because if he will look only at the note will say the child doesn't have allergies. So he will be happy, and they say, okay, I will give your child this antibiotics. And the parents may be aware, may look at the antibiotics and may tell him, no, our child has penicillin allergy. But there can be a communication, or there'll be misunderstanding. Some families think amoxicillin is not like penicillin V, is not like coamoxiclav, and they don't know. And so the documentation, the checking and rechecking, as well as the capacity and the workload within the system. The alert, as you have mentioned, especially if this child has been before, there should be an alert about that this child, when you come and prescribe, has got a previous allergy noted, and you have to look at it. So overall, from the 3 cases and the 4 that I've discussed, we have to appreciate and we have to recognize that errors can take place, and that as human beings, we can participate in these errors. And therefore, it is important that we appreciate that, but we try to prevent it from the beginning. And that by looking at the whole system. Okay, so this nurse may be in pressure, because if she did not do the right 15 minutes and she didn't write it, then she will be blamed. She should not. She should write the right times of the triage, even if she failed to see the patient within 15 minutes, because then the system will be looked at, and then people will look at the capacity. So what people should be looking for is an open and fair culture. People have to be encouraged to report any problems, not to blame others, but to identify where are the issues, if it's near miss or is it a mistake, and try to learn from it as a team. Because today, you may not be involved, but next day you can be involved in a problem, because the dynamics change within each unit and the factors will change. And how can we do things better together? And learning that it's not only you have to do your work properly. You have to get your competencies right. You have to improve your skills. There's no question about it, but you cannot on your own run the whole department. It is very complex, and every member has got their role, from the cleaner to the porter, to the dietitian, to the doctor, to the nurse, to the pharmacist. And we have to look at the best way to make our life better, that we can work easier and safer. I'll stop here because I think it's now half an hour more. Abdelgalil, how you have mentioned something, I will look at what you have said, and that will be, I can't see the chat. I don't know whether
Tagreed said, I think for us as IMG doctors, we are not much expert using SBAR technique for handover. That's the comment.
So it's good, Tagreed, that you have identified this. The SBAR, if you practice it, it's actually, and I always say, if you listen to someone who is a good communicator, and if you practice it, and I'm happy to do a session at any stage to go through it, then you can be concise and you can deliver a good handover. It comes with practice, and I'm sure you will. At the beginning, all of us, struggled with the handover. But at the moment, you learn, and with the huddle and attending. So what I tended to do, even if I'm not on call, I used to sit and listen to the handover. And we had an audit that someone was monitoring our handover when we were SHOs about the time we take and about the information we give, and then we have a feedback. And to be honest, I've learned a lot from that experience. And so there are different areas that we can look at within communication and handover. Rehab and Hani, you can discuss مع اللجنة and then decide. If there is no other question, I would like to thank all those who participated, and I hope you found the session useful. And if you have any question, you can send it to the organizing team directly, and I'm happy to answer these questions later.
شكرا سارة. إذا في زول عنده سؤال تاني, any other questions now, either put it in the chat or raise your hand or just unmute your mic and say it now. Otherwise, you can either email it to us in our email or through the website, contact form also. There are many ways of contacting us on all social media. I have one last comment on the human factors thing. There is Sarah already mentioned about the aviation industry and the military, which are using it for better than us, or they have been using it before the health system. There is a very famous story, which is the just a routine operation. If you Google just a routine operation, or if you put it in YouTube, you will see a brilliant video, which is all about situational awareness and human factors and how it affects everything. It's about someone who died, who shouldn't have died, if people acted properly. One of the things that happened in that scenario was, people were not able to challenge senior people. People were not able to raise their voice and say what happened, and this is what should be done. A nurse knew what should have been done in that situation. I'm not going to go into the details because of the time. It's about just a lady who was failure to intubate and needed tracheostomy, but no one thought of it except the nurse, but she was maybe felt not confident or not comfortable to speak up. Eventually that lady died, and her husband was a pilot. So he started talking about it, and he started making videos and talking about human factors and situational awareness and everything after that. So it's a good video to have a look at. So Google it. It's called Just a Routine Operation. The other comment is about the famous case of Hadiza Bawa-Garba. Probably all of you know about it. If you don't know about it, you should know about it. Also go and Google Bawa-Garba. A colleague who was involved in an incident that has been investigated by the GMC. It's a long case, but part of the important thing about the case in our today's session is that there were lots of human factors involved in her case, and they were considered when they were making decisions about her career and what kind of sanctions or anything to be imposed on her. She was on her first day coming from maternity leave when the incident happened. You can imagine what kind of mental thing she was going through. She didn't even have proper induction at the time. She was given 2 bleeps to cover 2 areas. One of her colleagues was unwell. The consultant on call was not on site. So a lot of human factor stuff, and system went down at the same time. She was not able to see the results for some lab works. So there are lots of things that were part of the case at the time. I also urge all of you who are either now working in the UK and haven't read about the case, or those who are intending to come, please Google that and read about the case. There are good summaries about it written by other colleagues on the internet. It's another case of human factors involved in serious incidents. Those were just my 2 humble comments. Anything else? Any other comments? Should we conclude? Rahab, عندك أي حاجة to add?
No, thanks.
Thank you, Sarah, for your time. And
Thank you all. Thank you.
Thank you. Thank you for your time. And please fill in the feedback form that is in the chat box. If you didn't get the chance to do that now, we will also email it to your email. Please keep an eye on the junk mail folder also, because sometimes emails go there. Your feedback will help us improve, and your suggestions will help us, devise further and future topics that are of help to people who are in pediatrics now. Thank you, everyone, and see you in the next activity.